So, mesenteric vascular disease may be classified as acute intestinal ischemia with or without occlusion, venous, chronic, arterial, central, or peripheral. So, mesenteric ischemia. So, how do we classify it? So, mesenteric ischemia should be classified as acute intestinal ischemia with or without occlusion, venous, chronic, arterial, central, or peripheral. So we have based on duration, it can be classified as acute or chronic. Acute or chronic. And based on location, can be central or peripheral. Central or peripheral. So the superior mesenteric vessels are the visceral vessels most likely to be affected by embolization or thrombosis, with the former being most common. So embolization is more common than thrombosis. Occlusion at the origin of superior mesenteric artery is almost invariably the result of thrombosis, whereas emboli tend to lodge at the origin of the middle colic artery. So occlusion at origin of SMA is occlusion at origin of superior mesenteric artery is mostly a result of thrombosis, whereas emboli tend to lodge at the origin of middle colic artery. Inferior mesenteric involvement is usually clinically silent because the collateral circulation is better. So one point is that inferior mesenteric involvement is usually clinically silent. Because collateral circulation is better. Possible sources for embolization of SMA, superior mesenteric artery, include the left atrium in atrial fibrillation, the left ventricle after mural MI, visitations on mitral and aortic valves associated with endocarditis, and an atheromatous plaque from an aortic aneurysm. Primary thrombosis is associated with atherosclerosis and vasculitis, including conditions such as thromboangiitis obliterans and polyarteritis nodosa. So, superior mesenteric artery embolization. Possible sources are left atrium in atrial fibrillation, left atrium in atrial fibrillation, left ventricle after mural MI, Vegetations on mitral and aortic valves. Associated with endocarditis and an atheromatous plaque from the aortic aneurysm. Associated with endocarditis. Number 4 is atheromatous plaque from aortic aneurysm. Atheromatous plaque from an aortic aneurysm. So these are the possible sources of embolization: left atrium in atrial fibrillation, left ventricle after mural myocardial infarction, vegetations on mitral and aortic valves in endocarditis, and atheromatous plaque from the aortic aneurysm. The next thing that can be is primary thrombosis. And when do we see primary thrombosis? So it is associated with atherosclerosis and vasculitis. Atherosclerosis, vasculitis. Including conditions such as thromboangiitis obliterans and polyarteritis nodosa. So vasculitis will include thromboangiitis obliterans and polyarteritis nodosa. So primary thrombosis of superior mesenteric veins may occur in association with factor V lead-in, portal hypertension, portal pyemia and sickle cell disease, and in women taking the OCP. So a specific form of non-occlusive mesenteric ischemia may complicate critical illness. A specific form of non-occlusive mesenteric ischemia may complicate critical illness, possibly due to alterations in the splanchnic blood flow. Okay, so this was superior mesenteric artery. Now we'll note down for superior mesenteric vein. So for superior mesenteric vein, so primary thrombosis can occur. We have a risk of primary thrombosis. So this can occur in association with factor V lead-in, portal hypertension, portal pyemia, sickle cell disease, and in women taking oral contraceptive pill. Women taking oral contraceptive pill. And we have read this line: a specific form of non-occlusive mesenteric ischemia may complicate critical illness, possibly due to alterations in the splanchnic blood flow. So there is also something known as non-occlusive mesenteric ischemia. That is what we need to know. Non-occlusive mesenteric ischemia is also there. It is found in critical illness. Irrespective of whether the occlusion is arterial or venous, hemorrhagic infarction occurs. The mucosa is especially sensitive to ischemic injury because of its high metabolic activity. The intestine and its mesentery becomes swollen and edematous, especially with venous occlusion. Blood-stained fluid exudes into the peritoneal cavity and bowel lumen. The changes develop rapidly and irreversible injury ranging in severity from mucosal necrosis and sloughing To full thickness infarction usually occurs within a few hours at most. If the main trunk of SMA is involved, the infarction usually covers an area from just distal to the DJ flexure to the splenic flexure. Usually a branch of the main trunk is implicated and the area of infarction is less. So, pathophysiology. So what happens is occlusion, whether it is arterial or venous, it causes hemorrhagic infarction. Hemorrhagic infarction. There is usually bowel edema. So bowel and mesenteric edema, and it is more with venous occlusion because of the decreased venous outflow. So blood-stained fluid exudes into the peritoneal cavity and bowel lumen. Blood-stained fluid exudes in peritoneal cavity and bowel lumen. And the most important point is that the mucosa is especially sensitive to ischemic. So the mucosa is sensitive, especially sensitive to ischemic injury. Due to high metabolic demand. These changes develop rapidly and irreversible injury ranging from severity from mucosal necrosis and sloughing to full thickness infarction usually occurs within a few hours at most. So there is a rapid and irreversible injury. Within few hours. And severity is from mucosal necrosis and sloughing to full thickness infarction. So we've seen that if the main trunk of SMA is involved, will cover the entire area from the DJ flexure to the splenic flexure. Usually a branch of the main trunk is implicated and the area of infarction is less. So now next is the clinical features. Clinical features. So the most important clue to an early diagnosis of acute mesenteric ischemia is the sudden onset of severe abdominal pain in a patient with atrial fibrillation or atherosclerosis. So in cases of acute mesenteric ischemia, acute mesenteric ischemia, will get a sudden onset of severe abdominal pain in a patient with atrial fibrillation or atherosclerosis. In a patient with atrial fibrillation or atherosclerosis. So this is the most important thing, that if there is a sudden onset of severe abdominal pain in a patient with atrial fibrillation or atherosclerosis, we can suspect acute mesenteric ischemia. And the pain is typically in central abdomen. Pain will be typically in central abdomen and out of all proportion to physical findings. Out of all proportion to physical findings. So the other symptoms are persistent vomiting and defecation, which occurs early with the subsequent passage of altered blood. Then we have passage of altered blood. So persistent vomiting and defecation occurs early. Abdominal tenderness may be mild initially, with rigidity being a late feature. Shock with features of both hypovolemia and sepsis rapidly ensues. So abdominal tenderness may be mild initially, and then rigidity is a late feature. And obviously there is shock, both hypovolemia and sepsis, features of both hypovolemia and sepsis. So what investigations we will do? So investigations: profound neutrophil leukocytosis with an absence of gas in the lumen of the thickened small intestine on abdominal radiographs and CT scan. Gas may be present within the intestinal wall and occasionally in the mesenteric and portal veins. So we will get profound neutrophil leukocytosis and absence of gas in lumen of thickened small intestine. Of gas in lumen of thickened small intestine and presence of gas within the intestinal wall. Within the intestinal wall. And now the treatment. So the treatment should be tailored to the individual in conjunction with full resuscitation, laparotomy with embolectomy via the ileocholic artery, or revascularization of the SMA, superior mesenteric artery, by vascular bypass may be considered in early cases. Anticoagulation should be implemented early in the postoperative period. However, the condition is usually diagnosed late in the disease process and the mortality rate is extremely high. In the young, all the affected bowels should be resected, whereas in the elderly or infirm, the situation may be deemed incurable. After extensive enterectomy, it is usual for patients to require IV alimentation The young, however, may sometimes develop sufficient intestinal, digestive, and absorptive function to lead relatively normal lives. In selected cases, consideration may be given to small bowel transplant. So let us see the treatment. So in treatment, first of all, treatment should be tailored to the individual. Tailored to the individual. And what we do first is full resuscitation if the patient is in shock. We have an option of laparotomy with embolectomy by ileopolic artery, laparotomy with embolectomy, via ileocolic artery, or revascularization of the SMA by vascular bypass. Revascularization of SMA, revascularization of the SMA by vascular bypass. Vascular bypass. And these are the surgeries we can do in early cases. So we can do both of them in early cases. But what happens is that most of the cases they present late. Anticoagulation in post-operative period. Anticoagulation is needed. Early in post-operative period. So if the patient is young, all affected bowel should be resected. In a young patient, all affected bowel to be resected. Young patient, all affected bowel to be resected. And TPN may be required. After extensive enterectomy. And in selected cases, we can go forward with small bowel transplantation. So next one is chronic small intestinal ischemia. Chronic small intestinal ischemia. So what happens is it almost invariably results from atherosclerosis and affects the proximal, superior mesenteric and celiac vessels. So first point is cause is mostly atherosclerosis. And it affects proximal superior mesenteric and celiac vessels. Proximal superior mesenteric and celiac vessels. So patients classically present with symptoms of severe central abdominal pain, comes on within 30 to 60 minutes of eating, mesenteric angina, weight loss and diarrhea due to malabsorption may also occur. So what are the clinical features or symptoms? So the clinical features. So clinical features are those of mesenteric angina. Mesenteric angina. So what is mesenteric angina? Mesenteric angina is severe central abdominal pain within 30 to 60 minutes of eating. Within 30 to 60 minutes of eating. So this is mesenteric angina. This is the number one clinical feature. Then we have weight loss and diarrhea due to malabsorption. Weight loss and diarrhea due to malabsorption. The condition may be difficult to diagnose and is often overlooked initially, the symptoms being mistaken for those of peptic ulcer disease or irritable bowel syndrome. The presence of significant vascular disease on visceral angiography is common in elderly patients and in those with severe vascular disease, and should not necessarily be assumed to indicate that abdominal symptoms are attributable to chronic ischemia. So in elderly patient, if we do visceral angiography, there may be significant vascular disease, and but this should not necessarily be assumed to indicate that abdominal symptoms are attributable to chronic ischemia. So treatment is usually by selective visceral angiography with stenting angioplasty, and where that is not possible, bypass surgery. Smoking cessation is imperative and patients are usually anticoagulated. So diagnosis or imaging. So for imaging we have visceral angiography, and then for treatment. So in treatment what we do is selective visceral angiography followed by stenting angioplasty. Selective visceral angiography is followed by stenting angioplasty. And where that is not possible, bypass surgery. If not possible, we need to do bypass surgery. Bypass surgery. And this is number 1. Number 2 is smoking cessation and anticoagulation. Smoking cessation. And number 3 is anticoagulation. So this is the treatment. So in chronic small intestinal ischemia, the cause is mostly atherosclerosis. It affects the proximal, superior, mesenteric and celiac vessels. Clinical features are mesenteric angina, severe central abdominal pain within 30 to 60 minutes of eating, weight loss and diarrhea due to malabsorption. Imaging, we do visceral angiography. Treatment is selective visceral angiography, which is followed by stenting and angioplasty, which is, if not possible, we go for bypass surgery. Smoking cessation is imperative and anticoagulation is usually done. This completes mesenteric ischemia.